So now that we've finished ECG basics, let's get started with sinus rhythm and variations. Here is an outline of sinus rhythm and variations. We're going to look at normal sinus rhythm, sinus tachycardia, sinus bradycardia, sinus pause, sinus arrhythmia, arm lead reversal, dextrocardia, and northwest axis. So first of all, here is a ECG showing normal sinus rhythm. You can see that there's a P wave preceding every QRS wave. And again, the best place to look for P waves is in leads 2 and V1. Also in this ECG, you can see a normal precordial progression with a small R wave and a deep S wave in lead V1. And then the R wave progressively grows through the precordial leads to V6, where you see a very tall R wave and very little S wave. So this is an appropriate precordial progression. So here's an ECG that shows sinus tachycardia. The definition of sinus tachycardia is a rhythm arising from the sinus node in which the rate of impulses exceeds 100 beats per minute. Now, using our rate determining principles from earlier, we see that between one QRS and the next QRS is about 2.5 large boxes. So that equals about 120 beats per minute. You can have sinus tachycardia, which is physiologic. So for example, if you are running, or if you are under stress, or if a patient has anxiety about something, then very commonly they can have sinus tachycardia. But there's also inappropriate sinus tachycardia that is associated with disease. For example, a patient who has sepsis, or maybe inappropriate sinus tachycardia from an overactive sinoatrial node. These would be examples of pathophysiologic sinus tachycardia. Next is sinus bradycardia, and the definition of sinus bradycardia is a rhythm arising from the sinus node in which the rate of impulses is below 60 beats per minute. And let's calculate the bradycardia here. So the distance in large boxes between one QRS and the next is about 5.5 large boxes. And so using our rate determining principles from previously, that's about 55 beats per minute. Sinus bradycardia is common in athletes with enhanced vagal tone. It occurs more often during sleep, and also certain cardiovascular drugs, for example beta blockers, can cause sinus bradycardia. So here's an ECG that shows a sinus pause, and this is syndromic of sick sinus syndrome, which commonly occurs in elderly patients when their sinus node begins to slow down. It can be a common cause of dizziness and syncope or passing out in the elderly who have sinus node dysfunction. And sometimes you can have a sinus pause related to obstructive sleep apnea or a carotid sinus massage and carotid sinus hypersensitivity. You can also see this in long QT pause-dependent ventricular tachycardia. But the bottom line is that a sinus pause is usually a sign of conduction system disease, especially in the elderly. And the guidelines for pacemakers state that if a patient has symptoms, for example dizziness or syncope, and they also have sinus pauses of at least 3 seconds or greater, then that would warrant, in most situations, the placement of a pacemaker if there's no contraindications. Let's take a look at how much of a pause we have. If we count our large boxes, then we can see we actually have a 2.5 second pause here. So next is a sinus arrhythmia. And what a sinus arrhythmia means is that the patient is having variations in their sinus rate by greater than 10%. And let's take a look. If we put some calipers on our QRS wave, for example, or we could do the same with the P wave. And then we slide the caliper over to the next QRS. We can see that there's a significant slowdown of our sinus rate, but seemingly no other abnormalities on the ECG. So this is sinus arrhythmia. It can be physiologic, and because we would expect a certain amount of variability throughout the day, especially in a patient who may be just finishing exercise or has just ingested caffeine, for example. But it can also be a sign of cardiac disease, and especially autonomic dysfunction. And you see autonomic dysfunction many times in patients who have heart failure or who have neurologic diseases or diabetes mellitus. Arm lead reversal. So here's a situation that we commonly see all the time in the clinics and on the wards, and that you may be asked on your shelf exams. So at first glance, this looks like a pretty normal ECG. But if you look a little bit closer, you can see that in lead 1, each wave is pointing downwards. That means that the P wave, the QRS wave, and the T wave are all pointing downwards. And this is the same for lead AVL, which, as you know, points at the left shoulder. Also, take a look at lead AVR that's pointing towards the right shoulder. The P wave is positive and the T wave is positive, and we definitely wouldn't expect that in the normal AVR lead. So this is actually a common example of arm lead reversal, where this patient actually had ECG leads accidentally placed incorrectly on the LA and RA, and vice versa. So the limb leads aren't the only leads that can be misplaced. Sometimes precordial leads, i.e. leads V1 through V6, can be placed incorrectly as well. And in this example, we would expect a normal ECG to have a smooth, progressively increasing R wave from V1 to V6. But we see that lead V2 has an inappropriately tall R wave versus the other precordial leads, and it's unexpectedly tall. And in this situation, this is a form of inappropriate lead placement of V2. Now here's an interesting ECG, and sometimes you'll see this in patients on routine physical exams. And you can commonly see this on your pediatrics rotations and in internal medicine shelf exams, and they like to test this a lot on both the shelf exams and the board exams. So notice here how the leads that point at the left shoulder, i.e. leads 1 and AVL, they have a negative downward pointing S waves and inverted T waves. Normally we would expect these to be positive, but like we discussed earlier, in this case it's negative. Also look at the precordial waves V1 through V6. Notice how the R wave grows in the opposite direction, from V6 to V1, which is backwards from what we would expect. So this is dextrocardia, meaning that the heart is in the right side of the chest and pointing at the right apex. On physical exam, we would expect to hear the heartbeat on the right chest and primarily breath sounds on the left. And here's a more rare ECG that we touched on a little earlier, showing a northwest axis. Remember earlier we showed that the polarity of the leads matters, and that the polarity of leads in lead 1, which is horizontal facing, lead AVF, which is vertical facing, and lead 2, which bisect both 1 and foot. That this is how we defined our axis. So if we look at these leads, we find a deep S in leads 1, 2, and foot. And these are all signaling depolarization that happens in a direction opposite from the normal vector of depolarization. And so this is a northwest axis because we see a negative QRS in leads 1, 2, and foot. You really need an extreme set of circumstances to get a northwest axis. Some of the diagnoses on the differential might include emphysema, hyperkalemia, lead transposition, ventricular pacing, ventricular tachycardia, and pre-excitation. So these are the most likely things that could cause a northwest axis.